Most cardiovascular risk assessment focuses on adult exposures and behaviors, smoking history, cholesterol levels, blood pressure, exercise habits. We're learning, however, that adult cardiovascular disease has roots that extend back to childhood and even prenatal development. The concept of developmental origins of health and disease suggests that early life exposures program biological systems in ways that create vulnerability or resilience decades later. Emerging research indicates that childhood cold exposure patterns may be one such programming influence, affecting cardiovascular disease risk in adulthood through mechanisms we're only beginning to understand. During childhood, particularly the first few years of life, cardiovascular and metabolic systems are developing and establishing their baseline operating parameters. Vascular structure, including arterial wall thickness and stiffness, develops during childhood. Inflammatory set points, the baseline levels of inflammatory markers that persist throughout life, become established early. Autonomic nervous system regulation, which controls heart rate and blood pressure responses, develops its patterns in childhood. These systems aren't fixed at birth, they're shaped by environmental exposures during critical developmental windows. Repeated cold exposure during childhood appears to influence these developmental trajectories. Children growing up in cold climates show different patterns of arterial development compared to those in warm climates. Some studies suggest increased arterial stiffness, which is a risk factor for hypertension and cardiovascular disease in adulthood. Inflammatory marker baselines may be elevated in populations with significant childhood cold exposure. These aren't necessarily pathological during childhood, but they create a starting point from which adult exposures operate. The mechanisms likely involve epigenetic programming. Epigenetics refers to changes in gene expression that don't alter the DNA sequence itself, but affect how genes are read and translated into proteins. Environmental stressors, including repeated cold exposure, can cause epigenetic modifications that persist throughout life. These modifications might affect genes involved in vascular function, inflammation, or metabolic regulation. The result is that two individuals with identical DNA but different early life exposures can have very different cardiovascular disease risks. This isn't suggesting that cold climates are inherently harmful to children. Evolution has equipped humans to adapt to diverse environments, and cold climate populations have survived and thrived for millennia. The issue is inadequate protection during critical developmental windows. A child in a well-heated home, with appropriate outdoor clothing, adequate nutrition, and protection from hypothermic episodes experiences cold exposure very differently than a child in inadequately heated housing, with insufficient clothing, poor nutrition, and repeated cold stress that overwhelms adaptation capacity. Socioeconomic factors create disparities in childhood cold exposure quality. Families struggling financially may keep heating lower to save on utility costs. Children may lack adequate winter clothing. Nutrition might be marginal, impairing the metabolic capacity to generate heat. These children experience cold stress rather than adapted cold exposure. The cardiovascular programming that occurs under stress conditions may differ from programming under well-managed exposure. Geographic migration patterns add complexity. Someone born and raised in a cold climate may have adapted appropriately, but their cardiovascular risk might increase if they move to a different climate in adulthood. Conversely, someone with childhood cold exposure may have different risk profiles when re-exposed to cold later in life compared to someone without that developmental history. This suggests that cardiovascular risk assessment should include questions about childhood exposures, not just adult lifestyle. Public health implications are significant. Ensuring adequate heating for families with young children isn't just about immediate comfort, but about long-term cardiovascular health. Programs providing winter clothing, weatherization assistance for low-income housing, and nutrition support during winter months have benefits that extend far beyond the immediate season. They're potentially preventing cardiovascular disease decades later. For adults, understanding their own developmental history provides context for current cardiovascular risk. Someone who experienced significant cold stress during childhood might benefit from more aggressive cardiovascular screening and prevention efforts. This isn't fatalistic. Epigenetic changes can sometimes be modified by later interventions, and knowing your risk allows for appropriate preventive action. The research on developmental programming and cardiovascular disease is still evolving. We don't yet have clear guidelines about how to incorporate childhood exposure history into adult risk prediction models. But the principle is clear: what happens in childhood shapes adult health in profound ways. Cold exposure, as one of many developmental influences, deserves attention in both public health policy and individual cardiovascular risk management.